26 weight engines. We're live. 11 people.
Perfect. All right. Fantastic. So we're ready to introductions. Good to go. All right. Thumbs up. All right. Welcome, everyone. I'm Dr. Chris Thompson, and I'm in Miramar, Florida, just outside of Miami. And I'm here with our team. And you can see here we have Alex and Tanya and Leilani over here, Dr. Lima. Juliana is over on the side here. I don't know if you want to pan over. And this is our team. And we have some of our other core Bariendo employees as well, like Sherry here and Chuck. So full team. And we have our patient, which you all know is Z. So he's one of our very own, and he's going to be getting a transoral outlet reduction today, a TOR procedure. So that is a revision of a gastric bypass. And so we're going to look at his anatomy here. So endoscopically, what you should be seeing, hopefully we'll be able to send this signal out. Okay, good, beautiful. This is a gastrojejunal anastomosis, okay? And this is the gastric pouch. So you'll notice that the pouch is pretty nice in length. I'll give you the measurements actually here, guys. It's 43, it's a little short. 45, about 2 centimeters in length. On this side, it's a hair short. So it's not a very long pouch. It's a little wide, but the outlet's quite large. And we know from various studies that an outlet greater than 15 millimeters in diameter is too big, and it does set the person up for a weight regain. So there's a risk of recurrence of weight gain. So that outlet's just a little too big. So then there's a small bowel beyond this, and his small bowel looks normal. So what we're going to do is we're going to prepare the tissue first by doing an endoscopic submucosal dissection. We believe this is a critical part of the procedure to get optimal outcomes. So it involves removing the mucosal lining of this area. We can advance the needle. What's that? Okay. So, and while we're going to oftentimes, this is a good opportunity to discuss some of this. So occasionally, this can be very fibrotic. And if that's the situation, you're going to want to start using an injection needle. We like using a Carlock needle in those circumstances. That will really help kind of get the lift. Additionally, there's different fluids you can use. So the device I'm using here is called the Irby hybrid knife. And this knife is special because it can inject fluid through the knife itself. And it does it at great pressure. So we're going to be using this device, and we won't actually have to start with a needle because we can actually inject fluid directly through this knife. So that's a nice advantage of having this. So we're going to start by just injecting the fluid into this tissue, and then we'll start making our incision. And if I got the green light, are we grounded and ready to go? Okay, good. So we're going to start right here. We're trying to just create a little pocket of fluid right there. Couple touches. We don't want to go too deep, obviously. We're going to kind of cut back and forth just to get in the right plane. I'm trying to find the submucosal plane here. It's natural to get a little bit of bleeding on the initial injection. We don't want to go too far away from the outlet because then the suturing device won't come out in the plane. And similarly, we don't want to go too close to the outlet because we want to make sure the stitches are placed deep enough and they're going to be robust enough. We're kind of starting to make our way around here. And with that initial kind of step, and I'm going to come in and I'm going to look, I'm going to try to see if there's any bleeding. Let's say we have some bleeding, we can try to stop there. You'll see some vessels here, right there. This is common. We're going to switch over to soft coag, please. So we have different settings. We like to go around using a cutting current. So we're taking down these vessels. See little red vessels that I'm taking down. Important to deal with this proactively. We have different pedals. This is the water jet coming from the scope itself. This does not have any blue fluid in it. This is good for looking for vessels. You can see there's bleeding right in the corner there. And then the injection fluid has a blue dye called methylene blue mixed in with it. That helps us to, again, lift the submucosal space.
What's the purpose of the methylene blue?
Methylene blue, it's really good in third space procedures because it helps you kind of delineate structures a little bit better. You know, you can, in particular, muscle. You want the muscle to stand out from the submucosal space. You don't cut all the way through it. And I find that the methylene blue does give you a better view of the submucosa, which is your target for the dissection. So that was the question, was why we like using methylene blue. So I think that's pretty good. I think we stopped the bleeding for the most part. We have a little bit in this corner still going on here, so I'm going to use more of the clear fluid. Kind of try to find the source of that.
Talk about how the cap helps you.
What's that?
How the cap helps you.
Yeah, so Sherry's mentioning the cap, how I'm using the cap. I like to use this cap to trap the fluid right here, and you can see there might be blood coming from under that lip. But you can also use the cap to press on the vessels and tamponade them as well. So there's a lot of different reasons why I like using a cap. Theoretically, you can do this without a cap, but I think it's more helpful to have one. So it's coming from up above, right up there. So I'm going to have to cut more to expose that area. So I'm going to go back to the other foot pedal where I'm injecting fluid under pressure. And it's the blue one. You know, switch me back to, actually, you can keep it on soft, coag. Your electrosurgical generators have improved so much over the years, and it makes this much easier to do. It used to be a very hard procedure. Now it's considerably easier. The waveforms that these generators produce are fantastic, and they really minimize the issues you get with bleeding. So now I've opened that up. As you can see, I'll be able to find this bleeding source a little bit better. You just got to work your way through it, kind of be methodical, take your time. The procedure gets much better weight loss than if you do not do the ESD. So it's worth the extra time and effort you're putting into this because the patients will do much better. So we got to always think about that. You can ask any questions in the comment section. Please feel free to ask questions in the comment section. We have Chuck Donalfo and Sherry are looking through there, and they're going to relay those questions to me. More vessels right there. You can see those. We're going to try to stop this. We're on soft coag.
Yeah.
Confirm? Thanks. All right. You want to take down those vessels as you go. Then we'll keep heading north. So you can see how nicely that fluid lifts when I step on the foot pedal. It really does a great job. And that's actually, it's a form of hydrodissection. It's dissecting through that soft tissue, the submucosal tissue right there. Before we had this knife, this hybrid knife, which injects at great pressures. What is the PSI we're injecting at?
Give me 1 second. The PSI is 435.
435 PSI. You know, your tires are at 35 or 40, right? We're at over 400 PSI for this dissection. It's like 30 bar probably. So I don't know what units you're familiar with, but that's a lot of pressure we're using. And it's kind of amazing how it dissects this just with water pressure. And then we can just make an incision. Without lifting, it's very dangerous because we're likely to completely perforate through the muscle. Here's another vessel right here. You get better at finding these vessels with time. We're still on soft, right? Very important to kind of take those down as you go. One question we had was, what are the complications you see with this procedure, and is bleeding more common because we're doing this dissection, right? And actually, bleeding is not more common. It's because we have the opportunity to go through here and seal all these vessels. So actually, bleeding might be even a little less common, just because when you go through and you suture this, you don't have the ability to take down vessels like we're doing during the ESD portion if you're just doing APC.
So we have a question unrelated to this procedure, but it's a question about balloons. Someone's asking how long a balloon lasts in the stomach.
So we leave the balloons in for 6 months, and that's what it's approved for in the United States. Other balloons that are on the way are shorter duration, and you swallow them, or they can be longer duration and even up to a year. And we expect those to be coming soon. But right now, you're looking at balloons that are in place for 6 months. So we continue injecting more fluid here and dissecting. At some point, I'm going to have to take the instrument out and kind of clean everything again. Right now, we're going to just keep going. We don't want to get too deep. You can see we're not quite halfway around yet. It's important to kind of make our way all the way around.
Is there a certain point that you typically start at to go around in a circle, or does it not matter?
So the starting point, generally, we pick the easiest part to start in, not the hardest. Sometimes we can close this device and pull this out. For some procedures, you want to start at the hardest location. I just want to clean this fluid out. You guys can brush that device. It'd be great. With this, you want to start at one of the easier locations because it's hard enough as it is. So right now, I just basically took out the device and I'm suctioning. We can, what are we on, medium there? We can go up to high on the suction temporarily, then go back down to medium.
Dr. Thompson, as she's doing that, quick question. What type of results do you expect from this procedure for Z, the patient?
So this procedure, as long as you're doing the ESD preparation in a purse string, you can get 12% total weight loss or higher, which is phenomenal for a revision procedure. When you're picking a center, you want to go to a place that definitely does a purse string. That's essential. But it's even better if you do a purse string with the ESD part of the procedure. 12%. If you don't do this, if you just do interrupted stitches across this outlet, you will potentially only get 3% total weight loss. So not a lot of weight, unfortunately. So you got to go to a place that's going to do this the right way and do a purse string, circumferential that we're talking about, not just a couple of stitches across the outlet. We'll point that out again later. Kneel out. When we start suturing, we'll show you kind of the difference between a purse string and an interrupted stitch. And then this part of tissue preparation, actually, not many places do this, but it's really important for those outcomes because 12% total weight loss is a great amount to lose after someone's already lost weight with a gastric bypass. Another question oftentimes that comes up is, when do you want to intervene? Someone had a gastric bypass and they're gaining weight again. When do you want to actually do that procedure? And as you can see, Z is doing this, what you might think is early because he hasn't gained a ton of weight yet, right? But what's happening with him is he's having recurrence of hunger. And I believe he's talked about this online. He's quite hungry and he's having trouble maintaining his weight. He's gone on GLP-1s. They weren't effective. And his weight is starting to come back on. That's a good time to intervene. You've already tried medicines, it's not working. You've adjusted your diet, you're exercising, you're doing everything right, and you don't want to lose all the ground you made with a good surgery, right? You don't want to wait until you regain all that weight you've lost. So I think it's good to intervene early rather than later, provided you're doing everything right as far as your diet, you're exercising, and you've tried medicines. So this is a good time for him to actually have this procedure. Don't gain 60 pounds back before you do it. Got another vessel here. You can see bleeding right there. Beautiful. We'll take these down as well.
Question from Facebook from Randy. How many of these procedures of this sort have you done over your career?
So I started doing this procedure in 2003. No, it's okay. So let's just go up on this section, please, back to high. So it's been a long time that I've been doing them. Actually had the idea for this when I was in training. I was at Mass General and Brigham up in Boston for training, and I thought about doing this, and we kind of patented the concept and worked on some devices, and I've been doing it ever since. So that's several thousand, cases over the years. With this device, we've done probably 2,000, I would say, out. And then with the ESD part of this part of the device, there's far fewer, because we've only been doing this for about 5 years like this. But it clearly has improved our outcomes. So here we're in a little area of scar tissue. It's not lifting quite like I want. So I'm expecting it's going to start bleeding and becoming difficult there. So a lot of times I'll come to this other area then and save that. So I'm going to switch up where I'm doing the ESD, and hopefully it'll be a little easier down here. And that lifted a little bit better. So we're going to continue down here. You don't want to put too much tension on this. Sometimes we have questions about what the right patient is for the procedure. I think that, again, this is anyone with a gastric bypass we're doing this procedure on. If you don't have a gastric bypass, you're not getting a TOR. That would be an ESG or a sleeve and sleeve procedure, which we also do offer, obviously. So this is for people that have had gastric bypass. And then you want them to have a dilated outlet, just like Z has here, it's a big dilated outlet. You also want to make sure they've addressed any other medical issues they have that can cause weight gain. So say they had a gastric bypass, they lost a bunch of weight initially, they start gaining weight. Make sure they don't have thyroid disease. Make sure they don't have some medical condition that could be responsible for that weight gain. You don't want to do a procedure that's not necessary. Additionally, you want to make sure that their diet and exercise is in line with what you want. Because if we do an outlet reduction and we bring this outlet down to the size it should be, about 8 millimeters, say, but patients are drinking, Coca-Cola, they're drinking calories, a lot of sugar in their diet, they're not going to lose weight anyway. So you want to make sure we fix that first. Then if they've done all that, they're still having troubles and they're still struggling, they're really hungry, then this is definitely a great option.
What does recovery look like?
So recovery, well, what's going to happen is after this procedure, Z is going to go out to our recovery room. He's going to be there for about 2 hours, get a couple of liters of fluid intravenously, and then he will go home. And he'll feel a little nauseous when he comes out of the procedure room here, and he will feel a little bit of a sore throat. So not bad, no pain like you would with actual surgery, right? But that's kind of what you'd expect to see. And then we'll treat the nausea with some medication, and we will also, maybe give him some Ativan, which also helps with that, and also can make people just feel more comfortable in general. And we'll send him home. And then his job tonight is just go to sleep. He's not drinking anything or eating anything today. He's just going to go home, go to sleep, and then in the morning he'll feel a good bit better. Additionally, our team comes and visits him tomorrow. They'll give him intravenous fluids, and here he's going to be staying in one of our partner hotels, and they'll go visit him in the hotel and give his intravenous fluids there. Or if someone goes home, our team will go to the home and give him intravenous fluids. And then after that, the patient really can start being very active right away. So this is a Thursday. He should be back to work on Monday, and certainly no later than that. But because he works for Bariendo, he'll be working later today. But everyone is chuckling. He will be awake and working later today. We don't recommend people do that, but you certainly can go right back to work. And we want a very important thing is to exercise after these procedures. He's going to start walking, even though he can't have anything to drink today. He's going to be walking today. You're going to walk. It helps prevent any blood clots, but also it's good to stay active. I think a real important thing to keep in mind is that after these procedures, it's like you're downsizing a house, okay? You live in a big house, you're moving to an apartment. What are you going to do? You're going to throw out the stuff you don't use. You don't want your body, when it's throwing out the stuff it doesn't use, to throw out muscle. So you need to be active. And we're going to be doing some actual footage tomorrow about what kind of exercises you need to do to make sure that you don't lose muscle as you lose weight. And I think that's something that's great about these procedures because you can be very active right away, shortly after the procedure. So here we go. We got one more vessel, and then we're almost done with this part of it, which is great. This is one of the longer parts of the procedure here. So again, it's got to be able to deal with the bleeding.
Question from Irene on Instagram. What does this procedure take?
So we'll see how long it takes today. But normally, when you're not asking questions and kind of doing a broadcast, you should be able to do this procedure in about 40 minutes. This was that area at the top we saved for last because it was very fibrotic and a little vascular in here. Then we're taking more time kind of looking through here. I think I see a staple for the surgery right there. And there's some more vessels up in here. So I want to take more time cauterizing these so it doesn't bleed later. Again, another advantage of this procedure where just trying to get right up in there like that. We might want to get a coag grasp first. Let's just see. I think it's okay. It's probably okay. That's a pretty big vessel right there. I don't know. You want to get it? Yeah, give me a coag grasper anyway. So we're going to use another piece of equipment here to seal this. Go ahead and pull that out and clean it, please. This is a slightly larger vessel, so we're going to cauterize it with a different piece of equipment. We probably could have been fine with that, but I always want to go around and touch it up. You can see here, we're going to go back to that other device as well, just in a few seconds. See, we're making our way all the way around. You don't want to make this terribly wide. You just want to make it wide enough where you can actually run sutures in this. So that's about the right width. There we go. You kind of come up in here and we're going to grab that. Open. You're on coag grasper setting now. You're going to do a little counterclockwise for me. Yeah, it's pretty good actually. Close. I don't want it up and down, but I think that's okay. I think that's okay. So here we go. Open. So this is a little grasper. Yeah, it's like a little forceps. It grabs the vessels and it squeezes them and then seals them together. Okay, so it's this way. Cross, horizontal. Yeah. So turn the whole device. Yeah, whole thing. There you go. Perfect. Perfect. Close. There you go. Nice. See the bubbles as sealing vessels. Open. So we're just going to go around and look for any vessels that look like they could be problematic. Close it. And we're going to touch them up with this because it's a nice way to seal vessels. Here's another one there.
Someone's asking if you can just talk about the procedures we do for our patients that have bariatric procedures and the patients that haven't had.
Yeah, sure. So the most common procedures that we do are ESG. So ESG is endoscopic sleeve gastroplasty, a stomach tightening procedure. So we also refer to as stomach tightening. And that is for people that have never had any prior surgery. And it's similar to this. We do it through the mouth, so there's no incisions in the abdomen. We run a bunch of sutures in the stomach to fold the stomach on itself and make it smaller. And that is the most common procedure that we do. Then we have sleeve and sleeve, which is people that have had sleeve gastrectomies, and they start regaining weight. And that's basically very much looks like an ESG. We run sutures in the stomach to make it smaller. And that does help them start losing weight again. And then finally, we have this procedure, which is for gastric bypass patients. This is the TOR procedure. And so this is for anyone with a gastric bypass. So those are the three most common procedures that we do in about suturing. Now, we also have intragastric balloons. And we do place those devices in patients that have not had surgery. If anyone has ever had any type of stomach surgery, they should not have the gastric balloon, because that is a contraindication. So you can see us using, there's another huge vessel right there. I'm glad we're going around methodically. Open, open, yeah, close. Good. We're going to seal this vessel up a couple different spots. Open, close. So you can see how we're just sealing this vessel. Open is scarring, is turning white, and is scarring down, close. So that's one that if we weren't doing it this way, it could have bled. See, this is why we do this. Close.
With so many patients on
Open.
GLP-1s, do you have them stop it for a period of time, or can they go back on them?
Yeah, so there's another question about GLP-1s. We're done with that. Now we'll go back to the other knife. So GLP-1 medications are certainly very commonly used nowadays. And as I told you, Z had tried them and it didn't work. They do work in some patients and they don't work in some. So I think they're a great tool in the armamentarium. And sometimes we'll try them, especially if someone's already had a weight loss surgery and they just need to lose a little weight, like Z did. He hadn't regained a lot of weight yet. We'll try medications first. And if they work, that's great. Sometimes they don't work. Let's go back to high on that. And if they don't work, we then will go to these procedures. However, some people don't want to be on lifelong medications. And so it's perfectly reasonable to do this instead of medications. Now, sometimes they send us patients, and they should have sent them earlier. They might have already gained 60 or 80 pounds back. In that situation, you might use this procedure and medications. You might need both to get the desired weight loss. All right. So now we have our incision that's all the way around here, circumferential. We've already gone through and we sealed most of the vessels. Looks quite nice. Sometimes what I'll do now is I'll use some more of this fluid. We can do it at 20. Just to lift one more time, make sure we don't trigger a lot of bleeding here. And then we're good to go. And then we'll see what it looks like. Cool. I'm just sealing a couple more vessels. Keep that closed. Yeah. Sealing those couple right there that look kind of.
Question from Ben on TikTok. Does insurance cover this procedure?
So it is rare that insurance covers this. There are some places where you can get insurance coverage. Up in Boston, it was kind of covered, and now it's being under review, and we'll see if it gets covered again. We think it probably will. In most other places, in Florida and most other states, it is not covered yet. We anticipate that now that it's an FDA-approved procedure, that this will start getting coverage probably in the next 3 to 4 years. But again, it's going to be patchy, and then most insurers, again, you can't say one insurance company might cover it, another one might not. So you kind of have to see how that plays out. But we're hopeful we'll start getting insurance coverage, over the next few years. Just kind of going around, making sure we can't cause bleeding. Trying to induce the bleeding here. Because if I can induce bleeding, I'll find another vessel I can seal. That'd be great. And it looks like I couldn't. So there's no active bleeding. It looks really good. We're going to now switch over to the suturing device.
APC.
Oh, APC. Sorry, APC. Yeah. Perfect. So this is one other thing we do like to do. Not necessary. However, we do have the ability to do it here, so we're going to. Now, this is what some centers do instead of doing this EST tissue preparation. They only do this APC. It stands for argon plasma coagulation. And this burns the tissue. And we want to make sure that when we're doing this, we're going to burn the tissue right here, the intervening tissue between the EST and the outlet. So this has not been proven that you need to do it, but I think it is helpful because I think you get a more accurate sizing with the balloon at the end when we tighten this down. Just trying to make sure that separates well.
Question from
70 watts.
GWW off of TikTok. Is this surgery similar to the VSG weight loss surgery?
VSG? What do you say? Oh, sleeve gastrectomy. Yeah. So this procedure itself is kind of very unique. There's not really anything like it. Now, surgeons have done procedures where they resize the outlet, but they have to make big, it's usually open incisions they make, sometimes laparoscopic, but they can't make it as small. They don't have the precision. We have 30-fold magnification in here, and they can't do it like this. So plus there's a lot more complications. So that laparoscopic or surgical approach, I would say, is substantially different, but they can make the outlet a little smaller. Regarding other techniques, they can do limb lengthening. That's one procedure that can be done to help people with gastric bypass and weight gain. Here we're using this laser. It's like a laser. It's argon beam coagulation here. So we're ablating the tissue with this. It's important to do this. You want to get this deep enough because you really have to ablate the tissue if you're going to use it. So we're using 70 watts and it's forced APC. That's the settings for the doctors out there interested in doing this. So other procedures, ESG, again, that's for primary procedures. So what's different with ESG is we just suture. We don't do this type of tissue preparation, at least not yet. So if that's ESG. And then sleeve gastrectomy, LSG, laparoscopic sleeve gastrectomy, that's for people that, have not had gastric bypass. But there are some centers that will convert the gastric bypass to a normal stomach and then do a sleeve. So there are some centers that do that. That's a very big surgery. But you can get a sleeve gastrectomy after a gastric bypass. It's just they have to return your anatomy kind of back to normal. And then, and then after that, they have to do a sleeve gastrectomy. So that's quite a complicated procedure. Not many centers will do that. That requires quite a hospital stay, and it's a little more complicated. Certainly not going home the same day after something like that.
When people have a balloon removed, do they sometimes prefer to have ESG?
So there's another question about balloons, and yes, sometimes when balloons are removed, they will have an ESG. I recommend several months of wait between when the balloon comes out and when you do your ESG. That's for a variety of reasons. One is that the stomach is a good bit thicker when you remove that balloon, so it's kind of ideal to wait a little bit. Additionally, you want to get the most weight loss from each procedure, so generally it's pretty good to wait between interventions. Even medications, you usually want a washout period. We can turn down that suction. Oh, that's medium. That's fine. Leave it at medium. And coming up, this is the hard area to work in down here. It's going to be the tricky spot.
Do you ever have to change how you do it based on the size of the outlet?
Do we have to change the way we do the procedure based on the size of the outlet? And sometimes the outlet can be very small. It's still very stretchy, so food it's not necessarily kind of large if it's sitting in a static position. In those cases, we might not go with as many sutures, honestly, because it's less round, right? So we're going to put in fewer sutures in this case. Sometimes it's very short. So this is a short pouch. It makes it harder. It's even shorter, centimeter. In those circumstances, we might not even do the procedure because it might not be safe. You want to turn the esophagus into a reservoir. So sometimes you can't do it. You want to make sure the pouch is long enough. That was a staple we hit.
Question from Instagram. Heal.
So generally, it looks like an it looks like an ulcer, a pretty nasty ulcer. Give you medications. I think good enough to clean this up. Give you medications, acid suppression medicine. proton pump inhibitor, meprazole is an example of that. We give those medications. Generally, you still have ulcers. By a month, it's pretty good, and by 6 weeks, it's fully healed. Generally, anything in the body takes about 6 weeks. Just going around looking at it, it looks like depth, it's the right width. We're going to be able to step the needle all the way around. I'm pretty happy with it. Up the fluid.
You want me to turn?
Does
this procedure benefit syndrome and not just bleeding?
That's a great question. Does it benefit dumping? Gastric bypass have dumping syndrome. The blood sugars might drop after they eat. And this has been proven in several studies now to be a great treatment. People that have diarrhea after gastric bypass, very well for those patients. More likely to get insurance coverage for it. So it looks pretty good. Probably lens because it's a little foggy. Go down and the suturing device. Suction down and alcohol.
Question about GERD as it compares to other procedure, surgical gastrectomy.
That's an excellent question. So reflux is not something we see after alcohol. This can be used to treat reflux, bile reflux. Noticed we've made the outlet very tight. This tends to keep any bile from the small bowel from getting up into the pouch. That's what it looks like. So it's quite nice. You see the blue stuff all the way around. That's on target for the device. It's not too wide, so you're not really increasing it. So that's gonna be a good target. So good. And you notice this is kind of a big outlet. The whole in one view. It's a little bigger than we. One of the poor guys struggling hunger because this outlet is quite large. It doesn't even really off into the screen there. Too. So that is a big outlet. But this is where the bile is. So if you tighten this down, you're going to be less likely to bile up here. However, if someone has a lot of acid in the pouch, you could actually make the reflux a little worse by tightening it down. You want to make sure someone already has reflux. We find out what the cause is. That cause bile or is it acid? And then that helps us with making a decision if this is an appropriate procedure or not. All right, so that looks good, and we're ready. So now we're going to change scopes. So for this procedure, scopes, you need a 6 endoscope with a cap on the preparation phase, which we just did, and that would be around the outlet, and it's got to be close to dissection to remove the mucosa. And why that's so critical is mucosa will stick to itself. Okay, and I'm trying to pleat that together. Mucosa will not stick to itself. That's why when you go to sleep at night and you wake up in the morning, you open your mouth. Stuck to itself, your mouth would all stick together. The main thing it does is not stick to itself, right? So what we're doing is removing that barrier so we can get this smaller. So people that do this procedure and don't expose that, they're less likely to get a good result in the end. And they have to rely more on medications and other things to get that weight loss because that mucosa is so resistant to that.
Question from G in Miami via TikTok. Do you scope the patients prior to look at the size of their outlet if they're doing a revisional procedure as such?
So I think that if you're lucky enough to be getting insurance coverage for this, the insurance companies will want that because they want to make sure that the outlet is contributing to the weight gain. I do not feel it's 100% necessary. I kind of like upper GI series. Because the main thing you want to do is rule out a fistula, right? Because another reason why someone can gain weight after this procedure is they could have a gastric fistula. And you want to make sure they don't have a fistula because that's kind of a different way you're going to approach that. And you can figure that out with an upper GI series. So, I think that you're going to know if it's big when you go down to do the procedure anyway. So we don't find it's absolutely essential. Now, if I went down here and I saw this outlet and it was a small outlet, I'd be quite frankly surprised because I know he's already tried GLP-1s. He has a great diet. He has a great exercise program. I'd be shocked if it was small, and it wasn't. So if you have patients you're questioning, if they're really adherent to the diet, I won't need that. Let's do more alcohol on this though. Okay. Then you probably want to take a look. But let me talk quickly about the device. So this is the suturing device we're using. It's the Overstitch device, now with Boston Scientific, right? And basically what this is going to do, this is a little suturing arm, and it's going to run suture all the way around in a circle around that outlet and pleat it together. And we're going to be passing this needle right here back and forth. If you can see on the screen there, between that needle driver, right there, that curved suturing arm, boom, right through the tissue, and picking it up with that little pickup or anchor exchange. So,
question from Andrew on YouTube: is this revision also done during the ESG procedure as well?
So during the ESG procedure, we use the exact same suturing device. Okay, exact same suturing device. However, we don't do the ESD yet. There is a version of this that we're studying in Boston where I have been actually tunneling and cutting the muscle. And we don't know if that delivers more weight loss or not, but we are studying it. So for now, it's only this part, the suturing, and it's a lot more sutures because you have a much bigger stomach. But we do use this device to do ESG. It's the same device and the same suture we put in, but it's a different pattern. So quite similar though. So here we are. And what we're going to do now is we're going to place stitches kind of right in this area where we kind of prepared the tissue. And I generally want to start kind of right down here at 5 o'clock. So when I cinch it, you'll see later we have to put a balloon out to size it. I'm not kind of crossing the balloon and the cinching catheter. So that's a little complicated. For doctors out there doing the procedure, you'll kind of understand what I'm saying, I think.
Another YouTube question from Andrea: what is the recovery time of this procedure?
Sure, good question, recovery time. So I'm going to get back to that in 1 second. I want you to show I'm not crossing my stitches here. I'm running the first stitch kind of under, the very first one's kind of important here. You want to go under this so you don't lock your suture. Otherwise, there can be too much resistance as you go for doctors out there. And you want to make sure you do an open running suture, not a closed running suture. Okay, that's one thing. Additionally, I'm pulling that needle back so I don't bend it. You got to be careful with that as you're reloading the device. Okay, so recovery time. The recovery time is not actually bad at all. Look at this. You look at, you have to be careful. I can cross that again, so I want to be very careful here. You have to. This is something you have to pay attention to. It gets easier as you go along the circle, but in the beginning here, you want to make sure you don't go over your stitch, or we'll lock it, and it'll make it hard to get all the way around. So see, that's a very big difference for us right there. A little subtlety. So recovery time. He's going to go home today. You know, he's going to not eat or drink anything. Going to go to sleep. But he's going to start walking around, even nice and walk around. And then he's going to take it easy for the weekend, doing a lot of walking, kind of getting used to the diet, drinking. His nausea and sore throat will go away over the weekend. And then he's going to start hitting the gym on Monday. You know, it's not going to be crazy, but he's going to start with some resistance training. Meredith here, who's our fitness coach, it's going to be awesome. She's in the room actually, and she's going to be taking him through some of the exercises. You can actually follow that online because Meredith will be over at Equinox here, Rooftop Equinox in Miami, taking him through some exercises with resistance bands and what we talk our patients through at home as well. So notice we're going around in a circle.
We had a couple.
Weight restriction on lifting?
So people ask about weight restrictions on lifting. So for 6 weeks, this is not going to be fully healed. Okay, this is definitely not going to be fully healed for 6 weeks. So you want to be careful, but really what you want to be careful of is how you treat it from what you're eating. You don't want to eat anything in those 6 weeks. You're on a liquid diet only, and you don't really feel like eating anyway, right? So you want to be careful. You don't want to guzzle water. You want to sip it. And there's a protocol we give patients, so they know how to be careful. So that's what's more important. Now, lifting, I don't want people doing Valsalvas. I don't want them struggling really hard, like really going aggressive with it. Because in doing that, you could potentially pop a stitch. Now, after 6 weeks, you can go as aggressive as you want. I don't want to do resistance training, but you don't want to be trying to aggressively build mass, shortly after this procedure. 6 weeks, go for it. But until that time, you're doing resistance training to maintain muscle mass, not to kind of build new mass. And they can definitely walk you through that very carefully. So I'm at a point right here where it's getting hard. I'm a little over halfway around, and this is the same spot that was really thick. So I'm going to try to get one more stitch in here. Then I'm going to flip the device over. But I think I can get one more stitch in there. It's kind of tricky. That's where it's folded funny too. I don't know. I want to try to, I might have to actually put the needle back on and go the other direction. It might be easier from the other side. I'm going to try to, I'm going to flip the device over and see if this helps. Like that. Sometimes that makes it a little easier. Kind of a tricky spot. Sometimes you need a grasper here just to lift it, because you want to be as full thickness as possible. It's pretty good.
Question from YouTube from Andrea. Are the sutures permanent?
These sutures are permanent. There also are some sutures you can use. Can I have the helix, please? Or a rat tooth. Is someone looking for a rat tooth? Perfect. So they used to have sutures called Vicryl that were resorbable, and those are pretty good as well. I think I'm almost getting through that one spot. So I'm just trying to lift this little lip of tissue here if I can. Close, please. You need a lot of equipment to do this. You got to be in a setting where they know they have the right equipment. Especially if you get complications sometimes during procedures, you have to have the equipment to treat those. No, open very gently, not all the way. Close. We can kind of lift that just a little bit. There we go. That's perfect. So, open.
Couple questions that have come in.
Close.
Maybe they missed the initial portion when we started, but the question is, does the patient know that we're going live today with them?
Oh, of course they do. So Z actually is as you know, he's part of our company, and he's actually been documenting his journal on social media, his journey on social media. So he's very much aware of it. Open a little bit there. He rotate up and down. You can actually go on to various forums. I think Instagram, maybe TikTok, perfect. Close there. And you can actually follow kind of some of his posts about this procedure. Open. Good. Close a little bit. Just want to get this tissue perfect. That's good, right? Close. We got to push out a little farther before we open it. Let me go over here. I'm going to back up a little bit. Open. That's perfect right there. Close. Now open. Trying to get that. Close. Good. There we go. So it's very rare we have to do this. Use this grasper to pull the tissue in one of these spots, but it's worth it. If you need to do it, you need to do it. You want to be as precise as you can with all this. Open and close. Good. We probably don't need it anymore. We'll see. And any broadcast you see, we've done them before. We actually have a separate consenting process that the patients go through. And they, they will be fully aware of this. We don't ever surprise people with it after the fact. So we're almost all the way around now. We'll be going to be very careful not to break the stitch at this point. There's a lot of tension on it, and it can catch a staple and break or something like that. So especially when you're almost done with the procedure, you don't want something like that to happen. It's very close to being done here. few more bites at most. I'm trying to get slack on that suture, and that's why it's important to make sure it's an open running suture this whole time. Otherwise, this can be very hard to do. You can see this is our stitch right here. This is the stitch that I'm working with now, and that was our first stitch right there. So it was all the way around, the full circle.
Did you talk about why you start in that location?
Yeah, so Sherry's asking, did we talk about why we started this location? I did. It's because at the end of the procedure, you want to make sure that the balloon doesn't cross under or over the cinch, because then it can be very hard to see. There'll be one more stitch after this. You can get the balloon ready. We're about done now. Oh, no. I got to. Just about done. So now this last stitch here, we pick it up on the other side because we're crossing under again, just like in the beginning. And this is our last stitch. There we go. We're going to come back. We're going to drop that. Now we're going to cinch this over a balloon. But before we do that, I'm going to suction a little bit, take both those out.
Question from Andrea on YouTube. How quick is this procedure?
So it usually takes me about 40 to 45 minutes. Sometimes I've done it as quick as 25 minutes. It kind of depends. It kind of depends on the size of the outlet, how many stitches I'm placing. If I'm talking through the procedure like this, they tend to take a little longer. But that's the range. Sometimes you can be quite fast with it. Is that on high? Go super high. That's on medium. There you go. That's better.
How do you determine how small to make the outlet?
So there's another question about how do we determine how small to make the outlet? Well, that's a work in progress. We know that under 6 millimeters is too small because those people tend to vomit, break their stitches, and not lose much weight. And we know that 15 millimeters is way too big, and those people all gain weight. So the answer is probably somewhere between 6 and 12, and we're settled at 8 millimeters right now. I think that's a pretty good size. So we're going to be able to, I'm just cleaning the field up here for cinching. We're going to be able to take a balloon down. So that's going down. There's a lot of bubbles.
For those that have joined late, the question
left.
is, what are you doing?
Just a little bit. That's a good question. That's enough right there, yeah. So we have a patient here with a gastric bypass surgery, and they had that for obesity. And they did very well with the procedure. And recently, they started gaining weight. So they went on various medications, like GLP-1s, and it didn't help. And they still were struggling with hunger and gaining weight. So we're doing a procedure now to stop that weight gain, make them feel full quick. And it's called a TOR, Transoral Outlet Reduction. And we basically have prepared the tissue by cutting through that mucosa all the way around in a circle around their outlet. And then we, let's put the balloon down. And we did put stitches all the way around circumferentially. Yeah. Medium high is good. We got to make sure that there's a little bit of blood on the left. I'm thinking I want to go take care of, but the stitches will probably do it.
Another question here.
Actually, before I put that balloon on, can I have a co-ed grasp? So you can see there's a little bit of blood still coming right here. It's getting thinner. Thanks. Let me put that down the other channel. You want to kind of treat this when you can.
There's a question that says, should I wait until after pregnancy to put this on?
Oh, wow. So that's a good question. This does help with fertility. So people that are struggling actually to get pregnant, this is a fantastic way losing weight is good for fertility. Rotate a little more, then open. I want it up and down. Perfect. Open. Close. See those bubbles? We're sealing a blood vessel right now for everyone. It was some bleeding, you can tell. I'm trying to treat that. Open. So basically, I'm using this little grasper, closed, to pinch the blood vessel and cauterize it. So we kind of burn it just a little bit, and it should seal it up. So we're trying to find the right spot. Open. Close. And sometimes we don't do this. We just want to cinch it. Pulling the sutures together should stop it as well. So I don't want to do too much of this, just a little bit. Open. Close. That's good enough for now. Looks like it's stopped completely, which is nice. Again, you don't have to do that, but I had this device already open, so I thought it would be good to do that. So the bleeding is stopped. That's a good thing. And now we're going to put the balloon down and size this. So pregnancy. Again, it can help people. Losing weight is good for fertility. I need you guys to puncture that little thing or push it down there for me. However, there we go. Say you've gained weight. This is a gastric bypass. You've gained weight. You're going to gain more weight with pregnancy most of the time. Some people probably will. So if you want long-term durability, it's probably better. If you can, it's probably better to wait until after the pregnancy if you can. And it's the same for any procedure. ESG, sleeve and sleeve. It's probably better for long-term durability to wait till after you have the kiddo, and then you can you can have this procedure. And you can have it pretty quickly. Another question we commonly get is, how long do I have to wait after having this before I can get pregnant? And with surgery, a lot of times the answer is a year. With us, we just want you to be able to eat a normal amount of calories so you can feed the kid. And that usually is a minimum of 3 months for this procedure. And for intragastric balloons, it's after the balloon comes out, it's 6 months. So somewhere between 3 and 6 months. If your goal is to have this to become pregnant, that's what we're looking at. So go ahead and blow that up to 7.5 if you want. And you're going to hold it right there. Tending towards 8 if you can. So now we're going to slowly kind of pull this down around that. Maybe go up to 8 and then drop it down just a hair, because it's not really big enough in my mind yet. And then go down to 7 and 3. Okay, that's good. I think that looks pretty good. And we're not going to do the stitching for a little bit. Go back a little bit. I'm going to rotate. That's better. Maybe right there. Don't let it come back at all. Though. Push out just a hair, but just a little tiny bit. No, push it out. I'll just go just a little tiny bit. There you go. No more than that. I'm going to come this way. I want you to stay where you are. Push out just a little bit. Out a little bit more. Just out of the scope a little bit more. There you go. That's perfect right there. So this is the tricky part. We did all this work. We want to make sure we don't ruin it. So I'm watching to make sure the tissue folds around that balloon perfectly, which it has. That's quite nice. And that's a 7. Good. I don't want any higher than 7 3/4. Okay, good.
Question from A. Rosie. How much weight can some patients expect to lose?
I've had people lose over 100 pounds with this. They needed to. So those people were quite on the heavy side of things, though. I think this looks pretty good. Go ahead. So, but most people, I mean, it depends on how much they have to lose. Then liberalize their diet a little bit. So go ahead and drop that now. Okay. Yeah, be careful. Do not let go with your left hand at all yet. Go ahead and close gently, slowly and gently. Mm-hmm. Okay, now you can go gradually more. Try to close it all the way. You can let go with your other hand. And go ahead, yeah. Balloon down, please.
How about commenting on weight loss as it relates to decreasing medications?
And then let's go with the suction up. Yeah, so most of the time we want to get people wash out period. Have the person come off their medications before we do this. We don't like having, kind of too much going on when we're doing this procedure. Some medications we do have to stop the procedure because they can't be taken in crushable or liquid forms, and that's a bit of a problem. So here now you can see the new outlet. It's just under 8 millimeters, quite a bit smaller. Very nice, right? It looks a lot different than when we first started. We will add medications back on at 3 months if we have to, but we try to get people off of them. And who wants to be on medicines their whole life if they don't have to? So that's beautiful. So that is a nice outlet. That's about perfect size. It's not like a pinhole where you're trying to find it, which is way too small. And it certainly is a hell of a lot smaller than it was. So we're very happy with that. But now what we're going to do is reinforcing sutures. So we find it's helpful to do this. We put a couple of stitches in just to kind of reinforce that. I think another thing that's good before you go to a doctor, see if you can see some of their procedures. You know, see what they've done. Maybe they videoed the procedure, you can see their technique online, etc. I need a helix for this. Maybe they didn't do live broadcasts, but you want to make sure you see what their procedures look like. It's not just before and after pictures. You want to see what the procedure looks like, because there's a lot of different ways to help people lose weight, medications and other things. You want to see what it looks like.
Is there several techniques taking place around the country as it relates to these weight loss procedures?
Yeah. So for this one, I mentioned again, if you just interrupt the stitches, I'm going to show you an interrupted stitch now. So you saw all the work we just did. It's a lot of work to get a beautiful outcome. This is what you want it to look like. Now we're going to reinforce it. Some people won't do this part. They just do the reinforcing part. This is not good. This is not enough to get the weight loss you need. It makes it look good in the short term. It doesn't look like this, right? But it looks good in the short term. But you're not going to get the long-term weight loss you need. There's several studies that show, Neil Loucher, there's several studies that show that purse string is better than interrupted stitches. It's not even debatable. Additionally, there's studies that show doing an EST is better than not doing an EST, that tissue preparation phase. So there's really no excuse to just put interrupted stitches in. And anyone can make someone lose weight by doing an interrupted stitch, putting them on a GLP-1 and high-fiving and claiming success. That's not what we're going for here. We want to make sure we do the right procedure. And the anatomy looks really good afterwards. After our goal. So this is what an interrupted stitch looks like. You saw what I just did. This is just the interrupted stitch right here. It's just 2 stitches, one across from the other like this. And they do that in the outlet. And that's it. Go ahead, come out. We're gonna cinch it. Now, there you go. That's a quick procedure, right? Not gonna get you long-term weight loss. We like this just for reinforcing our work. This is our last one, probably. We'll take these up for a final look. Okay. Go ahead and take that. Beautiful. Beautiful.
If the pouch was also big, would you do more work here? Smaller?
So the question is, if the pouch was bigger, would we do more work? And that is a definite yes. But this thing is a 2-centimeter pouch. We don't have the ability to. So I'm going to come out. We're going to go back down and take a look. Go ahead and take this off.
I'll take it off.
Yeah. So for our final appearance, any other questions we didn't get to yet? We're almost done. So this would be a couple-minute warning usually here. We might get more alcohol on this kind of. Let's go back up to high in the section, please. And actually, it's pretty good. All right, so it's our final appearance here. You can see our outlet, nice and tucky. We'll get to see that for sure. Very clean. Nice reinforcing shot right there. That's a nice. And with that, I think we're going to come out. Questions?
Do you do these procedures over the weekend?
I think we do them on Saturdays here. In our Miami location, we can do them on Saturday. That's quite nice. Beautiful outlet. Good job, everyone. Great. There. Love it. Very nice. Thank you. Yeah, you can stop recording. And
Follow us.
so that's it.
If you do follow us on any of the platforms, you will receive $250 discounts while signing up for a procedure.
Thank you, Chuck. Fantastic. Thanks for joining us. You can follow us on all the different platforms, YouTube, etc. And you follow Z's journey as well. He's going to actually show you what it's like, show you what it's like the first night, and he's going to also show you what it's like to start that exercise program. It's important to stay motivated. And then Sherry, the Skinny with Sherry, the follow-up. Thank you for joining us, and hopefully we'll see you again soon.